Hi everyone, I'm Dr. Anisha, your microbiology faculty, and today's session is very crisp, very high yield, and I have included all the recent updates which are present in the national guidelines. And for this session, we will firstly be talking about all the definitions which are associated with drug-resistant TB. Then we'll be discussing about MDR and XDR-TB majorly, and all the recent treatment regimes which are included in the national TB guidelines. So coming to the definitions, we first need to know all the resistant patterns and all the types of resistance which are seen in patients infected with tuberculosis. So the very first definition is mono-resistant TB. So what do we really understand by mono-resistance? Mono always stands for one. So this definition includes TB caused by Mycobacterium tuberculosis strains which are resistant to only one first-line anti-tuberculosis drug. So that's the only thing we need to remember, that resistance to only one first-line anti-tubercular drug, AT3, right? So, what are the first-line anti-tubercular drugs? So, we have a mnemonic for this. It is RIPE, which includes rifampicin, isoniazid, pyrazinamide, and 𝗘𝗵𝗄𝗏. So, there is going to be resistance to only one first-line anti-tubercular drug. That is very important. Now, coming to the second definition, which is isoniazid-resistant TB. So this comes from the definition itself, the name itself, isoniazid-resistant TB, which is defined as any tuberculosis which is caused by Mycobacterium tuberculosis strains which are resistant to isoniazid. So there is going to be resistance to isoniazid and rifampicin resistance has been ruled out. There is no rifampicin resistance present. So mono-resistance can include any of the four and first-line anti-TB drugs, right? Whereas isoniazid resistance includes only resistance to isoniazid. Next comes the most important definition, which is the MDR-TB. What do we understand by MDR? So it is multidrug-resistant TB, which includes TB caused by Mycobacterium tuberculosis strains, which are resistant to, firstly, there is going to be resistance to rifampicin, plus there is going to be resistance to isoniazid, which is also represented as H. There's going to be resistance to rifampicin, isoniazid, and also there can or cannot be resistant to any other first-line anti-tuberculosis drugs, with or without resistance to any other anti-tubercular drug, right? And these are first line ATTs, right? So MDR includes rifampicin resistance, isoniazid resistance, and there may or may not be resistance present to any other first line anti-tubercular drugs, right? So these conclude the very first definitions which are most commonly asked. Then comes more complex definitions that are pre-XDR, XDR, and polydrug-resistant TB. So before understanding pre-XDR or extensively drug-resistant TB, we will first talk about XDR-TB. So XDR says that Mycobacterium tuberculosis strains or TB caused by MTB strains which are fulfilling the definitions of MDR-TB. So what is included in MDR? It is INI-CET, rifampicin, with or without resistance to any other first-line ATT. So MDR-TB definition is fulfilled. Along with that, there is going to be resistance to two more important groups. So there will be resistance to fluoroquinolones. And what includes fluoroquinolones? There can be resistance to moxifloxacin or levofloxacin. Why only these drugs? Because these are the drugs which are included in the national program, national guidelines for TB treatment. So there is going to be resistance to fluoroquinolones. Along with that, there is going to be resistance to other group A first line drugs, group or drugs included in group A. And what are those drugs? There can be resistance to bedaquiline. Currently these two drugs are included, or 𝗨𝗏𝗔𝗟. Right? So MDR definition has to be included. Then there is going to be resistance to any of the fluoroquinolones, whether moxi or levo. And there's going to be resistance to any drug, any of the drugs which are included in group A, that are bedaquiline or 𝗨𝗏𝗔𝗟. So this concludes the definition of extensively drug-resistant TB. Now let's see what pre-XDR mean. So for pre-XDR, the same definition goes, wherein Mycobacterium tuberculosis caused by MTB strains which are fulfilling the MDR-TB definition. MDR-TB is going to be there, and along with that, there is going to be resistance to only fluoroquinolones. Only fluoroquinolones, which can include either moxi or levo. So what is not present in pre-XDR? There is no resistance to group A, beta or 𝗨𝗏𝗔𝗟. Easy? So do not get confused between pre-XDR and XDR. XDR is included in three things, three group of drugs, and pre-XDR excludes only one group of drug, that is group A beta or 𝗨𝗏𝗔𝗟. So in order to remember the drugs, it gets very confusing to remember the drugs included in XDR or MDR. So let's first see a simple mnemonic, which is for MDR. Let's remember a mnemonic. I miss her. I miss her. So for MDR, we have resistance to isoniazid, and we have resistance to rifampicin, that is included, with or without resistance to any other first line drug, and M stands for MDR. Easy. For MDR, just this simple mnemonic will make you understand and memorize, will make you memorize all the important drugs. And for XDR, let's expand this mnemonic to I miss her because I love her back. So what do we include now? I will include isoniazid. R will include rifampicin. So this is including the MDR-TB definition. And for M, we will be using this for moxifloxacin. Right? And then L in this particular mnemonic would be used for levofloxacin and linezolid, and the last letter B would be included, would be used for bedaquiline. Right? So this has completely undertaken all the important drugs included in these two groups. And for XDR, we can very well derive the pre-XDR definition. Right? So now this concludes all of these important definitions. Then comes polydrug-resistant TB. So for polydrug-resistant TB, there is going to be resistance to isoniazid, there's going to be resistance to rifampicin, and there is going to be one or two drug resistance from the first line anti-TB drugs. There can be one or more, right? So what is the difference between MDR and polydrug resistant TB? MDR is including isoniazid, rifampicin with or without resistance to any other first-line drugs, whereas polydrug resistant TB is including resistance to isoniazid, rifampicin, and there is of course going to be resistance to one or more first-line anti-TB drugs, ATTs, right? So now talking about the last definition, which is rifampicin resistance. So this definition includes TB caused by MTB strains which are resistant to rifampicin. And what are the methods do we really use for detecting the resistance? We are using majorly genotypic methods, which include the molecular methods to detect any form of resistance pattern, right? So resistance to rifampicin, which is detected using phenotypic or genotypic methods, with or without resistance to any other TB drug. So there is only going to be resistance seen for rifampicin. And the catch in this definition is that this rifampicin resistance can be seen as monoresistance, wherein there's going to be only rifampicin resistance from the first line ATT drugs. There can be poly-MDR, wherein rifampicin is going to be present, or rifampicin resistance, which is included in all the definitions, right? Only rifampicin would be resistant, no other drug would be seen. And this resistance can also be seen in XDR-TB, right? So majorly we're focusing here on rifampicin resistance, excluding isoniazid, right? So now we'll be talking about the different drug groups which are included in the National TB Guidelines and are used for all the treatment regimes. So we have Group A, Group B, and Group C drugs. So Group A drug, which we have already discussed, includes the levo or moxifloxacin. So these are fluoroquinolones. And the other drugs are bedaquiline and linezolid, for which we have already discussed in the definitions. Group B includes clofazimine, cycloserine, or terizidone. And Group C is including all the other drugs, ethambutol, delamanid, pyrazinamide, imipenem, celastin. These are recent additions. Meropenem, amikacin, which is injectable, streptomycin, ethionamide, protonamide, and para-aminosalicylic acid, right? So you do not need to learn each and every drug group-wise, but these will be asked in your exams as questions from the treatment regimes. So now let's talk about the regimen options. So once the TB patients have been identified based on the eligibility criteria, so there is one committee who decides on to the treatment options for the patients based on their eligibility, based on all the other factors, right? And what is this committee? This is Nodal Drug-Resistant TB Center, or it is going to be District Drug-Resistant TB Center Committee. So these people decide the treatment regimen for the patients, right? So what are the regimen options available? So first regime is BPaLM. All the recent updates. Then the other option is shorter oral 9 to 11 months rifampicin-resistance or MDR-TB. Shorter oral course, whereas the third one is 18 to 20 months longer oral MDR or XDR-TB. So these are the three regimens or three regime options, treatment options, which are available presently and are included in the national guidelines. So let's talk about the very first regime, that is BPaLM regime. And this is the most widely accepted. It is the most suitable regime which is included regime for patients of age more than or equal to 14 years. And I'm talking about the first treatment option, that is BPaLM regime. Now this is the first choice of treatment in patients, in eligible patients of age group more than equal to 14 years with MDR or rifampicin-resistant TB, irrespective of their fluoroquinolone resistant status or HIV status. So this is the very first treatment option which is updated in the national guidelines. So before talking about the regime itself, we first need to know what is to be added along with this treatment regime and what needs to be avoided alongside. So what are we adding? We all know for the treatment for the patients who are on anti-TB drugs, they are given P6 or pyridoxine as supplement. Pyridoxine is given to reduce the incidence of neuropathy. So pyridoxine has to be included. It is very, very important. And what needs to be avoided is the use of magnesium supplements or any magnesium containing antacids which contain magnesium. Before consuming any of these drugs included in the BPaLM regime, we have to ensure that we do not use magnesium. Why? Because magnesium is going to act polyvalent cation and it is going to bind to fluoroquinolones, which is going to form immune complexes, fluoroquinolones, which forms immune complexes, and it rapidly reduces the absorption of all the antibiotics which are included in ATTs. So we are strictly going to avoid magnesium supplements, right? And these particular drugs, of course, everybody knows that these have to be taken with food. So let's talk about the regime, BPaLM regime. So let's write it down as BPaLM. So what do these letters stand for? So B stands for beta-quinolone, of course. P stands for pretrominant L stands for linezolid, and M is for moxifloxacin. So what are the dosage which are included? So bedaquiline for first 2 weeks, 1 to 2 weeks, it is given as a dosage of 400 mg daily. And from 3rd week onwards, 3rd to 26 or 39 weeks, it is given as 200 mg 3 times a week. 3 times a week. Then the next drug, predominant, it is given as, it's same for all the weeks, that is 1 to 26 or 39 weeks. This particular drug is given as a dose of 200 mg daily. And how do we remember that? 3-TO. TO stands for 2. So I have learnt it this way, that it is given as a dosage of 200 mg. Right? Then comes linezolid. Most of us know it is given as a dose of 600 mg daily. And it is also the same week pattern. It is 1 to 26 or 39 weeks. And to remember moxifloxacin dosage, so divide M in 4 particular lines, 4 lines. And it is given as a dosage of 400 mg daily. Again, same for 1 to 26 or 39 weeks. So this is the regime, the total regime along with the dosage which is given in all the eligible patients of age group more than equal to 14 years which have the status of MDR or rifampicin resistance, which is the very important thing included in this is irrespective of any fluoroquinolone resistance or HIV status. That needs to be remembered. Now coming to the next option, that is shorter oral MDR or rifampicin-resistant TB regime. So we have 2 regimes, that is linezolid regime and or ETO regime. So we have 2 different regimes. So for linezolid regime, it is said that these are all the short forms and the expanded forms are provided in this particular list. So linezolid is only given for 2 months. So this particular phase, it is the intensive phase, and this part includes the continuation phase. Right? So now for intensive phase, we have the very first drug, that is linezolid, which is only given for 2 months. And the next 4 drugs, that are clofazimine, then pyrazinamide, and then ethambutol and high-dose isoniazid, these 4 drugs are given for 4 to 6 months. 4 to 6 months. And the last drug, which is bedaquiline, mostly it is given for 6 months, but it can be extended to 9 months based on the prognosis and treatment progression of the patient. Right? This has concluded with the intensive phase drugs, linezolid, clofazimine, pyrazinamide, ethambutol, and high-density isoniazid, high-dose isoniazid, and of course the bedaquiline. So this is included in the MDR and rifampicin-resistant status patients, right? And the continuation phase includes levofloxacin, clofazimine, pyrazinamide, and ethambutol, all given for 5 months, right? So it is 9 to 11 months shorter oral linezolid regime. And if not giving linezolid, there comes the next regime, which is 𝗖𝗛𝗔𝗓 regime. So what all are included in this? So linezolid has not been included in this regime. Apart from linezolid, we have included 𝗖𝗛𝗔𝗓 and all of these drugs, levofloxacin, clofazimine, 𝗖𝗵𝗔𝗓, 𝗖𝗵𝗔𝗡 and high dose isoniazid, these are given for 4 to 6 months, right? So this is the intensive phase and this is continuation phase. So the longer oral regime is this is the shorter one itself, 9 to 11 months. So these particular drugs are given for 4 to 6 months, whereas the last drug, that is bedaquiline, mostly it is given for 6 months, which can be extended to 9 months based on the prognosis or progression of the disease. And the last 4 drugs are given, these are the same as the linezolid regime, that is levofloxacin, clofazimine, pyrazinamide and ethambutol. So it is the 𝗖𝗛𝗔𝗓 which is included in this ETO regime, right? So now coming down to the next treatment regime, which is the longer oral MDR or XDR-TB regime. So it is for 18 to 20 months. And these are the drugs which are included, which says that bedaquiline is again given for 6 months minimum to a longer period as well based on the progression of the disease. And the all other drugs, levofloxacin, linezolid, clofazimine and cycloserine, these are given for 18 to 20 months. So why are we considering this longer oral MDR or XDR regime? So the patients who cannot be initiated on BPaLM or 9 to 11 months shorter oral MDR regime due to any reason, it can be ineligibility, there can be an additional resistance pattern which is seen in the patient, whether the patient is intolerant to certain group of drugs, and there is non-availability of any of the drugs in use, or there is emergence of exclusion criteria. So all of these criteria, eligibility, any other resistance, there is shortage of a drug. So all of these cases will be treated or they will be modified, and longer oral MDR or XDR-TB regimes will be prescribed for such patients. And what is the maximum duration of treatment? Of course, it is going to be 18 to 20 months only. So maximum is going to be 20 months itself. So this particular session has included all the recent information which is important for your exam point of view. That's it for today. Thank you.